Welcome to a short introduction on cardiac arrest. At the end of this presentation, you should be able to appreciate and understand why we must react quickly in cardiac arrest, the different algorithms in cardiac arrest, and what else we can do for our patients after our team has successfully resuscitated them. The outline of this lecture will take you through what is taught in the Advanced Cardiac Life Support course in Singapore. However, it does not replace the actual course, which is a 2-day affair and involves the use of simulation mannequins to help you learn. Also, algorithms for pediatric and neonatal patients are slightly different, and drugs are weight-based. Hence, you must attend the respective courses if you are to care for these group of patients. So what is cardiac arrest? It is defined as the cessation of normal blood flow due to the failure of the heart to contract effectively, and the causes vary in adults and children. The essence of resuscitation is speed, because time is myocardium. The faster you recognize an ill patient and call for help, the earlier you commence CPR, and quicker you defibrillate the patient, the better the outcomes are for the patient. You will find that patients who collapse out of hospital often have poor outcomes, unless they were attended to by bystanders who are well prepared. Once you have recognized that someone is in cardiac arrest, call for help immediately. This means activating the Code Blue team by pressing the Code Blue button that is above every patient's bed in the hospital. While waiting for help, ensure that the environment is safe for you to resuscitate the patient. Then begin basic life support by following the acronym ABC. Cardiopulmonary resuscitation consists of 1 cycle of 30 compressions and 2 ventilations. Remember to check for carotid pulse after 5 cycles. If you have access to an AED or an emergency cart, attach the pads and deliver a shock as soon as possible. We will talk about AEDs later on in this lecture. To put it scientifically, cardiac arrest means one of these 3 things: ventricular fibrillation or pulseless ventricular tachycardia, pulseless electrical activity, or asystole. VF and pulseless VT is treated with unsynchronized cardioversion and IV adrenaline. Consider amiodarone or lignocaine if the rhythm is refractory to shocks. The so-called cycle of resuscitation is CPR drug shock, with CPR being uninterrupted throughout. This is the latest ACLS algorithm for VF and pulseless VT, in which the first dose of amiodarone has been increased from 150 mg to 300 mg push, meaning it is given as a fast bolus. The second possible rhythm in cardiac arrest is PEA, which involves CPR and IV adrenaline. While resuscitating, run through your mind about the possible causes of collapse in this patient. Usually, 2 or more hits are better than 1 in such a scenario, and it might involve looking through the case notes and online laboratory results while the resuscitation continues. Asystole must always be confirmed on more than 1 lead, and remember to check the amplitude as well. The algorithm is the same as in PEA, as are the causes. In the latest American Heart Association guidelines, atropine is no longer included in both PEA and asystole. This is how the latest ACLS algorithm looks like. Use the 5 H's and 5 T's to help identify the cause of PEA or asystole. Here are some practical notes for your reference, because you might be called upon to assist in the drawing of drugs during a resuscitation. While it is often the nurses who help us, it is useful to be familiar with the common drugs in the crash cart, especially adrenaline. Be aware of the alternative routes that you can give your drugs, which can be sometimes forgotten because everyone is focused on setting an IV cannula. Adrenaline can be administered via the ETT, but at twice the IV dose. After we have successfully resuscitated the patient, there is a lot more to do. We must treat the precipitating cause of the collapse and ensure the patient is able to maintain perfusion for the resuscitation to be considered truly successful. There are many aspects of post-resuscitation care. Targeted temperature management means ensuring that the patient is at least normothermic. Therapeutic hypothermia is available in suitable patients because it has been shown to improve neurological outcomes. Evaluate the patient once again in closer detail and investigate and treat as necessary. Also, consider starting vasoactive drugs that help with cardiac output. Other simple interventions you can do include controlling a patient's hypocount. Neurologic recovery is the true goal of our resuscitative efforts, and there is much research going on how to improve outcomes. Current research has shown that targeted neurologic assessment can be done to help us predict a patient's neurologic recovery. These are details that are beyond the scope of this lecture. What is often not mentioned in resuscitation manuals is communication. No matter if we are part of the ward, emergency, or critical care team, we need to be able to communicate not just with each other, but also with the patient's family. It is crucial to handle the family's expectations well. Before we end this lecture, we will talk about AEDs, which are found in most public areas in Singapore. These portable machines are useful and easy to use, but there are a few points that need to be noted. If you encounter a pediatric patient, you can use adult pads even if the AEDs do not come with pediatric pads. And in all patients, do not peel away the pads if placed wrongly, because this might cause the pads to not adhere well and decrease the efficacy of the shock.